Really excited to have a chance to speak with you today on advanced primary care and how it drives a return on investment. We're fortunate to have a couple of fantastic panelists that are going to be both presenting as well as answering some of your questions. I'll go ahead and start, and then I'd love for the panel to introduce themselves. My name is Nirav Vakaria. I'm a internal medicine primary care physician, still in practice. I live in Cleveland, Ohio, and I have the privilege of serving as the Chief Health Officer here at Marathon Health, where every day I get to work with great and motivated care teams that are excited to participate and practice in this model of advanced primary care that we're going to talk about in a moment. And I'm joined by a couple of colleagues today. I'll start with Marcus Such.
Thanks, Nirav. As he said, my name is Marcus Such. I am Marathon Health's chief actuary. In my role and in my team's role, we get to do candidly a lot of fun analyses in order to kind of see, hey, what impact is being had, whether it be on claims, whether it be on other things, other biometric categories, things of that nature, as a result of this program, and then in return cycle this information back through in order to help Nirav with his management of the overall care teams and clinical teams. That's kind of the primary roles that I serve here. With that, I'll pass it to Tiffany.
Thank you, Marcus. Good afternoon. I'm Tiffany Cumby, Group Vice President with Marathon Health. In my role, I serve in a region in the East, overseeing the client success and operations for our clients. I've been with the organization a little over 7 years, but I've been in the space of employer-sponsored primary care for over 13 years. And I've really had the privilege to see the powerful impact that it can have on the lives of employees and their families. Today, I'll be filling in for Trisha Griggs, who is a 10-year client of ours. Unfortunately, she had a last-minute conflict and was not able to join us. She is incredibly disappointed to miss this conversation today, but she did ask that we share a message with you all, and I'm honored to read it on her behalf. Hello, everyone. I'm extremely disappointed I'm unable to participate in the conversation today. As you are all aware and can attest to, unplanned situations occur and can totally disrupt even the best of plans. I want to take a moment to thank Marathon for inviting me to be a part of this panel to discuss ROI and the incredible transformation we've experienced at AFLAC since implementing the Marathon AFLAC Care Centers and Care Anywhere. Without a doubt, these services are some of the most, if not the most, popular benefit we offer our employees. Dr. Vakaria, Marcus, and Tiffany will walk you through some powerful data and statistics that clearly show why organizations like AFLAC need the offerings of Marathon Health. But I'm not a numbers person, I'm a people person. And if you know Trisha, she really is a people person. When I think about ROI, I think about our employees like Rachel, who just wasn't feeling right. She visited a care center and was ultimately diagnosed with cervical cancer. Or Nigel, who came in for a routine physical and blood work, only to discover he was in the early stages of prostate cancer. And most recently, TJ, who thought his thyroid medication needed a tweak, but ended up being diagnosed with thyroid cancer. I'm happy to share that because of early detection through our care centers, all three beat their cancers and are doing well today. So my challenge to you is look at ROI a little differently. Don't just measure success in dollars saved, measured in lives changed. Celebrate the stories and consider what it means to provide access to care that catches something early when it can still be treated. I hope you enjoy today's presentation and wish you the best. Sincerely, Trisha. Well, I'm disappointed Trisha isn't with us today. I'm honored to be able to share in something I too feel deeply passionate about. Nirav, I will turn it back to you.
Thanks, Tiffany. Very powerful words from Trisha. And also appreciate the fact that you are a former client of Marathon before you decided to join us, so you can speak from both of those perspectives as you carry her voice forward. Great. So a little bit of housekeeping. If Marcus and Tiffany and I just hear our own voices for the next hour, I think we will be disappointed. We hope that the Q&A section of your Zoom interface starts buzzing with your questions that you'd like to have answered as the content comes up. And I've already prepared Marcus and Tiffany that I'm going to stop them mid-sentence if I have to answer your questions in a really timely way. So please make sure you know where your Q&A button is in your Zoom interface, and please start asking questions as soon as they arise. We're going to have a little bit of a slide presentation into which we will incorporate your questions as the time is right, as well as a section saved at the end to answer your questions as well. In addition, we'll have some poll questions. So in fact, we're going to go ahead and just kick one off right now. Ben, if you're able to load up the poll. Great. So you should see something pop up on your screen. What has your healthcare cost trend been in the last 5 years? Please go ahead and answer. Okay, let's see what we have. So we have the majority of stakeholders represented on today's call between 6 and 9%. So we're going to get into a little bit of how does that fit against some national trends that we'll talk about in a moment. But clearly those are high numbers, and I think we've all been saying for years this feels unsustainable. So that's a lot of what we want to address today. So advanced primary care and ROI. What we'll be aiming to do is first just level set everyone. What is advanced primary care and how are we defining ROI? And you have Trisha's words that really talk about a much more holistic view. We're going to dive into some numbers, in particular with regards to the financial ROI that you can see from our analysis of over 300,000 members who have been through this for many up to 5 years, if not longer. And so we have both scale as well as longevity to talk about the impact of advanced primary care. I do want to start with that, though. What is so advanced about advanced primary care? I think we all probably have experience with some flavor of primary care. What makes it advanced, in our opinion, and it's not just us, but we know that there are others who provide this service as well. Actually, I think it's really about mastering the basics. It's actually a little bit about going back in time and saying what really worked back when primary care was financed and organized in this country in a way that made it possible for providers to sustainably practice for decades and be that sort of true long-term relationship, build that true long-term relationship with their patients, anchored on the fact that there was trust built because they were accessible, same next day, always able to get in, and that most importantly, the patients felt heard because they had that long-term relationship with someone they knew and they had enough time with that provider in order to have their needs not just be heard, but also met. And so it is about going back to the basics because we know those things work. There's 50 years of evidence that says the more primary care a person, a population, or a society experiences, the better all the outcomes are. It is the tide that rises all boats in terms of a clear dose-response relationship between the more you have of it, the more you have better clinical outcomes, utilization outcomes, and cost outcomes in terms of as we think about total cost of care for a person or a population. And so, unfortunately, though, nationally, that has not been the case that we've been investing heavily to make sure that that model thrives. This opportunity to really define version 2.0 or advanced primary care has come about in order to continue to treat the whole person, right? Because we know that if we get 40 patients with diabetes to be controlled in terms of their blood sugars, one case of transitions to dialysis in the future will be saved. Or we know that if we screen 1,000 people for colorectal cancer, one life will be saved. Or we know that if we screen 1,000 people for social risk, like food insecurity or housing insecurity, and actually work to address that risk by navigating them to the right place to get help, the emergency room utilization for that group goes down by about 10%. So as you look, there's ample evidence to know what works in addressing people's needs and lowering costs. But no one single point solution historically could address colorectal cancer screening and diabetes control and social risk. But primary care it's designed to do that. And as we think about advanced primary care, it's the platform opportunity to drive all of those things and not leave it up to specific or individual point solutions to help you get there. But we know that it's an investment. We know that having access to an advanced primary care center is not always something that's top of mind for an organization, for a CFO, as you're balancing the different needs of an organization. If I look at the trends that you all, 54% of you, have been facing of 6.1 to 9% over the last 5 years in terms of your renewals, what we hope to do today is to help you understand how that investment pays off immediately and actually continues to pay dividends in the subsequent years because of your ability to bend trend and just create value, both financially as well as that broader lens that Tricia mentioned. And so we've covered a little bit of this. I'm gonna just make sure again we're all on the same page about not just your experience, but nationally, what are we seeing? We're seeing renewal rates when we look at well-established and respected publishers of these statistics that are largely in line with what you're all seeing. And importantly, it's where are things going? Do we think it's going to get better? Well, one of the things we're all watching for is what is the impact of AI going to be on improving healthcare outcomes, for sure, but also what does it do to the cost of care? And I think it's really a big open question for all of us right now. One thing we can learn from history, though, is historically, typically, when you add technology to healthcare, overall spending actually goes up. Right? If we think about the adoption of electronic health records over the last 15 years, it drove a lot more improved billing and coding, which has driven up the cost of care. When we look at advanced imaging and things like that, unfortunately, the history has been technology makes things worse in terms of cost. It also certainly makes things better in terms of experience and outcomes. So as we look at those historical trends, I think we need to factor in some of what we're seeing today and make sure we try to get ahead of it. And what we'd like to position today is your understanding of just having more information of how advanced primary care can help you do that. And Tiffany, you spoke about some of the what patients are experiencing today in terms of trying to access good healthcare. Can you give us, both from Aflac's point of view as well as what you've seen broadly advocating for employees and their families, what are some of the statistics there?
Yeah, absolutely. So in a recently conducted wellness study, completed actually by Aflac, so we do see here on this slide, 54% of Americans frequently worrying about the rising cost of healthcare. But also to add, about 4 in 10 Americans are primarily using ER or urgent care for their health needs. And then nearly 1 in 5 Americans indicate they do not have a primary care physician. So they are not established with a primary care physician, solely using urgent care and ER.
Yeah, so certainly those are the stats. I think individually, each of us, either personally or in our family or in our friend circle, has experiences of struggling to get access to a provider who actually knows you and can get you in a timely manner and spend enough time with you, which is really what's needed to drive all of the good downstream outcomes that we're interested in. So let's geek out now. I'm going to hand it over to Marcus, our chief actuary, to walk us through some of the math of the impact of advanced primary care.
Yeah. Thanks, Nirav. So yeah, as he said, I was kind of tasked with, hey, we've got advanced primary care. Here's what we believe it is. Here's what it is. Can we actually take a look at the underlying information, the underlying data to see, hey, what is the impact of having one of these programs in place? Especially from a financial perspective and as it relates to the impact on healthcare claims, all the trend information that was just being shared by Nirav and Tiffany. And so we kind of took this approach. We did 2 analyses. They're kind of laid out here on the slide for you. The first one was trying to answer, hey, what's the impact for a client with a program like this over time? And so I've affectionately, as an actuary, I've affectionately referred to this as analysis 1 because I am not a marketer and I'm very poor with naming things. So analysis 1 is looking at, for overall clients, what's the impact had? That analysis represents approximately 89,000 lives spread across about 29 clients that had enough robust claims information that we could do this in-depth analysis. It is looking over a 5-year time period for each one of those clients and represents information ranging all the way from 2011 all the way forward to 2024. Again, with 5-year time periods per client interspersed between those for looking at that impact. Once we have that, and I'll go through the results of that here in just a second, but once we have that, naturally the next question is, oh, well, how did those results occur? What were the drivers behind that? And that's what analysis 2 is meant to kind of answer. And that's laid out here on the bottom. That analysis is, instead of being longitudinal through 5 years, that one is looking at a 12-month time period and saying, okay, in that year, how did those who were utilizing the program compare to those that were not, as a control group, if you will? That represents almost 250,000 lives with again, robust enough information for the analysis, and 60 clients. And it's looking at mid-2023 through the middle of 2024. Across these analyses, again, just from a size perspective, it does represent over 3 million claim records and over $1 billion in healthcare claims spent by health plans for looking at, where these impacts being driven from. So Nirav, if you want to advance to the next slide, we'll go ahead and get into the first analysis 1. As a reminder, this is the one that's looking at, hey, across these clients, what's the aggregate large scale impact? There's a very fancy chart on the left here that kind of tries to help describe it in a diagram fashion. In general, the idea here is that we took the ongoing claim rate that was occurring for any particular client, and we set a baseline. This was using claims from before they had the program implemented, and it was just straight up saying, hey, on average, how were your claims performing? And in this case, and you can see here, their claims were performing at a rate of about $413 PMPM. That stands for per member per month, or per belly button per month. It's effectively the number of lives each month, running at about $413 PMPM. From there, we then take that baseline and we project it forward as if nothing changed. The advanced primary care program didn't get implemented. Things just kind of ran with the natural healthcare market, which, similar to how most of you answered on that poll, has a general healthcare trend of somewhere in the 6 to 9% per year range. And by doing that, we see that the baseline would follow that red line on this chart, which would mean that in year 1, we would have expected the average claim rate to be $443 per member per month, and then climbing to $473 and $502, and just that never-ending stepping up of healthcare spend. Instead, the healthcare program was put in place with advanced primary care. And so then we look in year 1, hey, what was the actual average claim rate that occurred instead of what we would have expected? And that's what the gray is showing. So in this case, that baseline actually decreased on average down to 409, and then 405 and 404, and you can follow. Beyond that, you then also need to net that against the cost of putting that program in place. Because again, it's not all savings. There is a small cost in there. And that's what the purple represents. In this case, an average PMPM of about $28 in that first year. Put another way, that means in the first year, the average was a net savings of about 1.2 to 1. Or put another way, for every dollar invested in advanced primary care in the first year, on average, $1.20 in savings was returned. And that's what's shown in the table on the right. That follows through all the 5 years, and you can see that it grows over time. And this is part of the effect that Nirav was referencing a minute ago of bending the healthcare trend rate. If you can keep that down, like the advanced primary care seems to be doing for all these lives and all these clients, it can have a magnifying effect over time. Because instead of seeing 6, 7, 8% healthcare trend every year, instead, our clients are seeing closer to 1 to 2% per year on average. And it, again, has a really strong impact, as you can see out there in year 5 at $3.70 returned for every dollar invested. So it's just a magnifying effect. Again, those are the results for in aggregate for the clients and what's kind of being seen. On the next slide here, we're going to get into the drivers behind those results. And so Nirav, if you don't mind advancing one.
So we've got our first question. And so a reminder to everyone, you can enter questions and we'll try to answer them as we go. But we have one brave soul who's cracked the ice and is asking, Marcus, are these results uniform across those 29 clients that they got to a 1.2x ROI in the first year?
That's an excellent question. So absolutely not. And what you would expect is that you shouldn't see absolutely everybody seeing the same result. Some groups are going to have a higher claim rate to begin with. Some are going to have a lower one, and it represents different opportunity to generate savings. And so in this particular case, what we saw was approximately 65 to 70% of clients saw that net positive savings in the first year. The remainder did see either staying equal, flat, or a bit of a net investment in that first year instead of a net savings. By and large, I believe by year 2, I want to say it was 85-90% of clients saw that net savings. So again, it's going to vary client to client. And as I remind some folks from time to time when I talk through these subjects, there are absolutely some cases where the program is just not going to be a good fit. It's not going to generate the net savings. And we try our best to do that analysis up front. I will tell you these results, however, do show that for between 65 and 90% of clients in that first year, there will be a strong net savings. There is a small bubble in the bottom left. I did kind of glance over it instead of reading it at you, but given current market conditions, what we've seen across the board, and our current practices as we continue to scale and provide inherent savings to our clients, we would now expect over 80% of clients over 80% of prospects joining as clients to see that net savings in the first year. But it is by no means uniform. It's just a range of where those savings occur. Excellent question.
Thank you. All right.
Was there another question, Nirav, or should we advance?
Nope, that's what we have so far. Go ahead.
Okay. So as I mentioned a moment ago, that was analysis 1, looking at aggregate results. This is analysis 2 that goes into, hey, where are those savings coming from? And for this one, we used almost 250,000 lives, over 60 clients to try and address, hey, where are those drivers coming from? And you can see the results on this slide here. What we found when we compared those patients that were engaging with Marathon, and by definition here, the definition of engagement is at least 2 visits with a Marathon provider, because we're trying to measure those that are truly having the intervention, if you will. So at least 2 visits over an 18-month time period, and we are only looking at adults because children are their own story over here. So we're only looking at adults for this particular analysis. And what we found was that we found the rate of claims utilization or care utilization was very different between the 2 populations. And that's what some of these arrows are showing on the left. So for example, we found that primary care usage or utilization was increased by 82% for those that were engaged with Marathon versus those that were not. And this leads to a whole slew of other strong impacts that Nirav was mentioning earlier in this webinar of, frankly, saving lives, addressing the holistic patient, being able to actually take care of them, and reducing overall claim spend down the line. But again, 82% increase there. We saw for those that were engaged a full-on 9% reduction in the number of specialty care claims. So these are going to be dermatologists, cardiologists, oncologists, all the different specialties, if you will. We saw a reduction of almost 10% in those claims. We saw a 21% reduction in outpatient claims, so almost 1 out of 5 lower for those that were engaged with Marathon versus those that were not. ED visits or emergency room or emergency department visits, a reduction of 15% of those on average. 31% reduced urgent care visits, and a little more than 40% reduction in inpatient admissions. And a lot of that's going to be driven by, again, treating the holistic patient, taking care of things, doing screenings, so that we can keep them from having those, what I refer to as ticking time bomb episodes, where all of a sudden something extreme happens and they have to go into the hospital for a heart attack or some other severe condition. On the right, you can see these bar charts are showing some of the PMPM savings for engaged patients versus those not, again, on average. The bottom half of it is showing all patients. So again, that's all engaged with 2+ visits in adults. What we found was that the average claim rate was $454 for those not engaged, and only $361 for those that were engaged. So a little north of a 20% reduction in PMPM spend. And for that, we did provide one more view of those with 1 or more chronic conditions. We wanted to see, okay, what's the impact for those that have more stuff going on, if you will. And true to form, we saw strong savings there from, again, that treatment. Those unengaged showed about a $565 PMPM, and those engaged was about $452. So again, a strong reduction, a strong savings, well over $1,200, $1,300 per each of those individuals per year. Again, I'm using a little bit of nomenclature here. I do want to make sure that I'm crystal clear. When I say PMPM, what I'm referring to there is per member per month, which as a reminder from the last slide as well, that is treated as per life per month, per belly button per month. It's meant to look at all the lives that are on your plan per month. That's what's referred to there when I say PMPY, or if Tiffany or Nirav references PMPY, that's per member per year. So you're just looking at annual or monthly per person, just as a reminder.
Great. And Marcus, give us perspective. Where do these types of results compare to other interventions these days in healthcare? And Tiffany, please add in based on your industry experience as well.
Yeah, so from an actuarial perspective, looking at other solutions to affect healthcare, I will tell you that this is absolutely towards the top of the list from having an impact overall. I know that there's a lot of point solutions out there. There's a lot of other options that there's a lot of promises made. What I have personally found is that the evaluation for most of those come in a little bit shy of that. Not that they're not great programs, not that they're not generating savings from a financial perspective. However, the impact from having a holistic advanced primary care solution is absolutely towards the top of the list of being able to affect a health plan's claims overall and over time. In addition, having a massive impact for individual patients. Everything I described on the last 2 to 3 slides, somewhere in there, have all been from the health plan's perspective. In addition to that, there's also a strong out-of-pocket savings for employees and their families from being able to utilize a program like this, either at minimal or no cost, versus having to use a traditional fee-for-service office visit setting and having to incur co-pays, co-insurance, deductibles, etc. So this is truly a much more, I think I'm using the word holistic some 37,000 times on this webinar, but it is a much more holistic solution that has very positive results for nearly everybody out there. Tiffany?
Yeah, I agree with you, Marcus. Definitely seeing a lot of point solutions that are being brought forth, but this solution actually brings that integration for the patient from a primary care perspective. So I agree, bring that holistic, we'll use it again, patient care approach. I do also want to add, I know we talked, Tricia would have been represented here from AFLAC, but I do want to highlight, Marcus, too, some of the savings AFLAC is achieving. So they've been a client of ours for 10 years. They're achieving amazing results, but 2,300 in savings PMPY, so per member per year, for their engaged versus non-engaged members. It's about 27% of reduction. And then 76% of their at-risk chronic condition employees are making progress in their biometric improvements. And that's when we say the 76%, we're looking at unique members when we do that member total, because certainly members could be in multiple buckets. So great outcome.
Great. Tiffany, both from AFLAC's perspective as just your broader leadership within this space, can you walk us through the how with regards to how is this different for the patients? Why is it that they're able to access this and get these results when the broader healthcare system is much more mixed in terms of results? What's different about their experience?
In my experience, access and removing barriers. With a solution like this, we're removing barriers that you oftentimes face in the traditional community-based setting. Barriers, and sometimes it's just difficult for someone to navigate how to even make an appointment with a primary care physician who's in the network, right? That's oftentimes a challenge too. How do I navigate that? And then long wait times, taking 8 months to get established with a primary care in the Central Florida area. Removing that barrier that provides them that access where they have ease to be able to get care and get quality care, where a provider actually takes time with them, explaining their condition, and putting together a tailored, health plan approach.
Yeah, I think that's what these data show too, right? Is what's happened over the last few decades is care that should happen with your family provider has leaked out because we can't get in. And when you provide access, whether it's through something you have on site or near your site, or you access a shared clinic, there's lots of different options, as well as in the virtual world. You're just repatriating care back into where it should be, right? The scrapes and bruises and new back pains and new headaches as well as the chronic disease management, the prevention work that should happen in primary care comes back, and less of it's leaking out to the emergency room, the urgent cares, and whatnot. And Marcus, as you've dug much deeper into this data, you've noticed some interesting trends around how advanced primary care drives that impact on lower specialty and lower outpatient claims. Can you talk about what you saw? Because I think you and I were both a little surprised when we saw those results.
Yeah, absolutely. So, as you said, we see the reduction in the number of those claims. Frankly, again, because that care is kind of being redirected and prevented. So, whether that's through a patient coming into one of the health centers and being treated by that provider right there for something that could have been done in a specialty care setting, for example, dermatology. So I don't know, a skin something being removed, for example, or by utilizing some of the technology that we have in place, such that they're able to consult with specialists or others in order to receive the information they need to provide the care, instead of sending that patient out into the street, out to a specialist, having to have them go there, then go do testing, then have a follow-up, then et cetera. That whole spiral of specialty care, if you will, it really results in a strong reduction there. An interesting finding that we did find as well is that the average dollar amount per specialty claim or outpatient claim actually increased a little bit, even though the number of claims decreased. And that's actually an indication that we're helping those patients that absolutely need that care actually receive it. So while the average claim dollar went up, the number of claims went down by much more. So the net effect was a reduction. However, again, we want to make sure that those patients that need the care are receiving it, and that those that don't necessarily need it for the reasons that Tiffany and Rob just mentioned, that they have a one-stop shop, if you will, and are able to come through a health center and receive the treatment they need instead. So strong results. Oh, go ahead, Narv.
No, the party is definitely starting in the Q&A section, so I want to give folks answers to the questions that they are thoughtfully entering. Let's stay on this analysis for a moment, but then it sounds like there are some broader questions around how do we staff these centers and how do people access them and who are the providers in these centers that we'll also get to. But Marcus, there's always a valid question or concern around cherry picking in terms of these data, or around how you might adjust for differences in risk between the engaged and the not yet engaged subcohorts within this very large group of members that we've analyzed. Or we all know that a couple of really high cost claimants can really change the contours of these results. Can you just talk through some of the deeper work you've done to make sure that we're trying to get to a real good sense of apples to apples comparison of what's actually happening when you adjust for everything?
Yeah, absolutely. And these are some really good questions. Shows a really astute audience here. So to answer a very direct question about adjustments for risk and adjustments for large claimants, for example, and that kind of variation, yes, we absolutely did adjust for both of these. In the first analysis, the one that was looking through a 5-year time period, we truncated claimants that had over a certain amount of dollars at a client by client level. So, for example, if the threshold was $100,000 and a claimant had $250,000 of claims in a year, we truncated them down and removed 150,000 other claims. The reason we did that is because some of their claims would be impacted by advanced primary care, but for those with large claim episodes, a chunk would not. Think things like car accidents or things that are completely outside the control of a program like this. And so we did that truncation exercise for all the actual years of experience. We also did that for the baseline years of experience as well, because to Narav's point, we want to make sure that we did an apples to apples comparison. And so we've performed that for both what we compared to and what actually occurred to make sure we're kind of looking at this program in particular. The other thing that we did do for that analysis was we adjusted for any plan design changes. So for example, if a client had, if they only had a PPO plan in place and they suddenly converted completely only to high deductible health plan, by nature, you would expect that those claims would go down from one year to the next. We adjusted for that by using CMS models and actuarial valuations in order to make sure that we were truly measuring the impact of this program and not just a reduction from a plan design change or from large claimant activity, things of that nature. In the second analysis here, we also did something similar with the large claimants. We removed them from the analysis so that we could, again, look at truly what's happening from that could be impacted from this program. We did remove those from both the engaged and the unengaged population. So again, for an apples to apples comparison. And because you're looking at two populations that are inherently different, we did perform risk adjustment there as well. We adjusted for things such as age, gender, as well as general chronic condition riskiness in order to make sure that we were looking at apples to apples. Because the last thing I want, again, as an actuary, is that I don't want to show you a result where suddenly the engaged group looks way better than the unengaged group simply because they're 40-year-olds and the unengaged are all 60-year-olds. So we perform that adjustment to make sure we're looking across the board evenly and accurately. Now, I mentioned all that about large claimants and risk adjustment and all that. We did actually also look at that population of large claimants. And so this is a little bit cutting edge, if you will, from the analysis, but I'm happy to share some of those results as well. What we did find is that for the engaged population, there were about 43% lower number of large claimants relative to those that were unengaged. So in effect, helping drive fewer patients getting to large claim thresholds. In addition, the overall claim spend impact that we had for those large claimants was on average a 5% reduction, which doesn't sound terribly huge, but we're talking about large claimants. So that actually translates to about $16,000 per large claimant per month. I'm sorry, per large claimant per year. So about $16,000 impact for those large claimants. So that was a lot of answer for that particular question, Nirav, but a lot of good information on kind of how this analysis was broken out.
Yeah, I have to tell you, I was really surprised because we don't often think as primary care providers we're having that kind of level of impact on things like that cause catastrophic claims like cancers and whatnot. But the fact that this analysis with enough N size powering it showed that we are having impact was really cool. There's a question that came in from an attendee, sort of still in your wheelhouse, Marcus, before we move on to Tiffany. Have you considered running this analysis on a matched cohort rather than adjusting for risk after the fact?
So we did consider that, and we've actually tried to do that once or twice. The reality is what we tend to run into when we're trying to do a matched cohort is that we find that it's a lot more accurate if we're utilizing the underlying population of unengaged patients against the engaged patients. And if you try to do a matched cohort for a good number of the groups that are in this analysis before aggregating them, then what you're going to land on is a lack of credibility. You're going to reduce the number of comparison points that you're actually looking at such that the results aren't nearly as reliable to perform this analysis. So that's one of the reasons why we rely on this approach in line with typical actuarial standards and methodologies instead of a matched cohort, if you will.
Thanks. Tiffany, Paul asked a question just around wanting to better understand the Marathon network. What is this? Are these similar to the community primary care practices, or where are they? How many are there? How do they look different? And then there's a follow-up question from an anonymous attendee of how are you actually getting providers and physicians in particular to come and work here, because there's a shortage across the country, specifically in primary care, but we also know we have mental health, physical therapy, occupational medicine. We have all those other specialties represented as well. Could you address some of that?
Yeah, absolutely. So I'll start with how do we recruit these and retain these providers? So we have especially from a provider standpoint, our physicians, our APPs, we have, last time I like to think it's like a 97-98% retention, but really recruiting them, really recruiting those positions. Oftentimes we hear, I really didn't think this model could exist because they've been in the community-based setting for quite some time. When they're they indicate, hey, this is like a dream provider model. I actually get to, have time with my patients, talk to them about their conditions. And in many pockets, especially in the region that I work with, oftentimes recruitment happens by word of mouth in their network. Where we may struggle sometimes, if it's an area where maybe that we do not have a lot of brand presence, we'll do a little bit more marketing, to get them in if it's not word of mouth. But oftentimes, we're really able to get them by word of mouth and people sharing their experience working with Marathon. And then once they come to work with us, they do not leave from a retention standpoint.
So these are our employed providers, just to make sure it's said out loud. And can you talk about these health centers that they work in? Where are they? How do employers or unions get access to them?
Yeah,
What are the
absolutely.
different ways they get access?
Sure. So we do offer a couple of different models and I think that's what's great is really giving clients the option of what model fits them the best. So certainly we have our direct partnership locations. We do have hub and spoke locations that we offer as well. And then from a network perspective, networks are in different areas. So for example, I can't name all of the exact locations, but we do have them in Orlando, we have it in Charlotte, and we have it in the Indianapolis area as well. And that really allows, for clients to be able to essentially buy access to those Marathon Health Centers. The scope is a pretty core scope that we offer in those centers. It's a perfect solution for clients that do want to buy in. Maybe they're not large enough to have a full partnership site, but do want to buy that access to their patients so that they are getting that patient experience from the advanced primary care model.
Great. So I think we're up to 100 plus centers nationally with density in those, I think 12 markets today, some of which you mentioned, where employers can send their employees. And we're finding also now with workforces being more distributed and less sort of coming into the central corporate office every day, that it becomes a nice way to create also parity amongst an employee population that might be distributed broadly. So maybe you have some population that comes into headquarters every day where it makes sense to have something on site or very near that site dedicated to the employees and families. And then for everyone else, you have the opportunity to join a network center, get the same model of care, in addition to the 50-state virtual primary care practice that we have to make sure everyone has the opportunity to participate. We also have a great question from another anonymous attendee around how do you screen your outpatient referral sources? How do we know where to send patients? So I'm gonna go ahead and start this one, and then Tiffany and Marcus, please weigh in. But what we aim to do is build that relationship with the patients and their families such that they see us as the first destination of care, that true medical home. And when we do that, and we again spend enough time and they have the accessibility that they need, we automatically see a drop in the referral rate. And I can just attest as a former health system, sort of fee-for-service primary care physician, having to see patients every 15 minutes didn't allow me the time to use my full toolkit to really understand what is causing that new headache. I know if I just had enough time and had the opportunity to ask enough questions and do the right exam, 70 or 80% of these cases, I'm sure I can handle. But since the next 3 patients are already waiting in my waiting room, I'm just going to go ahead and refer. It's actually easier for me. And so that has led to what I sort of described earlier as leaking out of care that really should and could be handled very effectively by a primary care provider. So we automatically see a drop in the referral rate just by turning this on. And then in addition, we can drive further drops in that referral rate by empowering all of our providers to have what's called e-consults. So right in the EHR that they use, the electronic health record, they have access to about 150 different board certified physicians in the country who are waiting for us to submit questions about that patient. So we can send the chart and we can pose a question and we can say, what should I do here? And typically these days we're getting answers back within 4 hours, which is great for the patients that their care is advanced in a really expedited way. And it's also great for our providers because they're learning in the process on these things that they needed a little bit of help with, but didn't need to send all the way across town to a specialist. So that further reduces the referral rate and kind of gets to some of the results that Marcus mentioned. But to the specific question that was asked around how do we, when we do have to send out to that cancer specialist or that gastroenterologist or that rheumatologist out in the community, how are we making sure patients get to the right destination? And right means a lot of things here. First and foremost, we look at a combination of quality and cost of care metrics that have been assembled for that specialist. The specific tool we use is called Garner Analytics. It's one of the industry-leading platforms that help you truly understand the value of the care that's provided by individual specialists out in the community. And so we work with our clients to build that preferred destination for various specialties, incorporating who's in their network already, who might they already have relationships and sort of have created a center of excellence with, and what do the hard data from Gartner tell us are the right specialists to go to. And as being truly independent in this space, not beholden to any large specialty group or health system that might exist in the market, we have the opportunity to do what's right for the patient and what's right for the client, as opposed to other organizations where the goal is to keep that care inside of their network, no matter what the results are, as long as it kind of continues to drive that keepage. And that's what health systems typically have been guilty of. And so when you take all of that together, it's what leads to the reduction in specialty claims, the reduction in outpatient claims, better patient experience because we're facilitating that transfer to that preferred specialist and back. And increasingly, we're building deeper relationships with them so that we can get to more innovative and novel ways of working together. For example, expedited or facilitated access pathways, IT integration to drive the records back and forth in a more seamless manner, and moving towards actually negotiating case rates on behalf of the client and the carrier so that we can bring down cost and improve experience and quality at the same time. So that's how we know that only a minority of care happens in primary care. The majority of cost, at least, if not care, is happening out in the specialty world. And that's our way of using primary care as a lever to influence that. But Marcus, Tiffany, what else would you add to just sort of how we work with the outside world, whether it's specialists or whether it's other vendors that the client might have already in place in order to deliver a more seamless experience for the patients?
Yeah, so one thing I would add is some of what you were indicating shows up again in the data that we have running through our systems, our electronic medical records, for example. One clear indication to me of the impact we have on reducing specialty care from having to go somewhere else and things like that is just simply in our referral rates. So, for example, in a fee-for-service setting or a health system setting, the average referral rate is about 20%. So that means about 1 out of every 5 primary care office visits results in a specialty care referral. To Narav's point, it's because that primary care office is swamped. They've got 3 other patients waiting. They can't spend the time to do the treatment, so they have to refer out. So about 1 out of 5. Our average referral rate is about 11%. So closer to 1 out of 10. Because again, we are going to refer out for what needs to be referred out, but those that don't need to be referred out, we're going to perform that treatment in the health center. So again, it's just another statistic that really shows that impact. Tiffany, anything you would add?
Yeah, I was going to just add to Narav's point, definitely, we're going to work within the client ecosystem to identify any of those, if it's looking at networks, looking who's in the network versus out of network, certainly going to take that into consideration when doing this. And then I will tell you the provider feedback for the e-consult is very positive. And also from the patient experience, when we're looking at using that tool for the appropriateness of referrals, if there is an e-consult that comes back, says, yes, this patient does need to see the specialist, we find that patients are more apt to keep the appointment, make the appointment and go because they've already had that initial review. So we're seeing compliance as well be more favorable when we're using that tool and then referring out.
Great. Tiffany, we have a great question that's come in that's right in your wheelhouse. What is our member engagement and how does it compare to fee for service? So let's talk about just overall engagement and then sort of let's repeat engagement. Do we market to the employer group or do you rely on the employer to market to their employees to really get patients to use this service?
Great question. So very early on in a client relationship, the first thing that we're going to do is really kind of do a deep dive in client culture. How do you communicate with your employees and dependents? What is the best vehicle to use to get the information out? I like to say when you've seen one marathon client relationship, you've seen one, because they all look a little different. So very early on, we're going to establish, who the preferential communication person is. We certainly have a marketing team that helps us to communicate. We have ongoing patient journeys where we're able to continuously engage the eligible patient population. But then certainly, one of the things that I will say is where we have the greatest success is where we do have an employer client that does come alongside, right, and market this as well. And so that we're marketing this together to their employees and supporting it. But we could do it either way, really based on, we're set up to do both, based on just kind of client preference.
Great. Let's go ahead and move towards some closing notes. And Tiffany, I'd love for you to just continue with what you were describing there, which is we started with this as an investment, right? It does require some extra work and some extra resource early on. Marcus established that for the majority of clients, it pays for itself in year one. What you invest here more than reduces your overall health plan spend. It's driven through that engagement that you just described. You used to work at a school district where I'm sure resources were scarce. Can you talk to us about the advice you have on how to build the case that this is the right investment to make because it pays longer term dividends for the population?
Yeah, absolutely. So, definitely, facing the rising cost of healthcare is definitely a challenge. And I think when you're looking at a solution like this, because oftentimes it is a very expensive line item, right, for a client's budget, especially if you're trying to make that business case study to the CFO, and they're looking at like this expense associated. Kind of in my experience, my recommendation would be like not to just think of like the rising health plan cost in a silo. Right. Think of it as a much larger, like strategic business lever that organizations need to pull. And so really just convincing the right leadership, so the decision makers, that really adopting and investing in a model like advanced primary care is really about framing it up for how you are going to move forward strategically. And it's really putting an investment in your people and their families by giving them convenient access to quality care that will, in the end, right, we get them engaging. It's going to, at the end, it's going to reduce your overall cost and spend from a health plan perspective. It accelerates return to work time. So we see from a productivity standpoint, right, we're seeing the employees return to work faster. They're healthier when they're at work. And really leading to overall strengthening employee satisfaction and retention. And so from the school district perspective where I was at is that we were looking to how could we provide access, but also how could we keep our teachers in our county? What separated us from the neighboring counties? Because we do know that employees will leave for a very small compensation increase. And we have actually seen great improvement in retention rates by being able to offer something competitive that other employers in the area do not offer. So I think really bringing a vision that it's not just looking at the health plan, but look at the overall larger population for your employees and dependents.
Great. And Marcus, I'm going to ask you to share a little bit of what's hot off the presses in terms of that broader definition of return that Tricia thoughtfully wrote and Tiffany just touched on. I do want to just make sure we address one of the questions that came through the chat before we finish. Oral health affects medical health. Does Marathon offer, or are we planning to provide dental services at our health centers? So just stepping back, our core services, and we're trying to focus on our core, the advanced primary care, embedded and integrated mental health services, embedded and integrated musculoskeletal care, which can be physical therapists, athletic trainers, chiropractors, health coaches, and nutritionists. That's the core. And then many clients are seeking a broader set to also be part of that core care model. And we have many examples where we work with partners who provide those services. We co-locate and we drive that sort of clinical and operational integration. That exists for dental care, for optical care, for massage therapy, for full service pharmacies, which tends to really delight many clients as well as patients because it helps you start to get control of your pharmacy spend, which we know is a runaway train right now. And so absolutely the model, whether it's on site with certain specialties or through that vendor ecosystem that you've already assembled, and we think about virtual handoffs of patients and sort of that more seamlessly integrated model of care that every patient deserves. But Marcus, finish us off with what you're seeing as we define return and value more broadly. So Tiffany talked about some workforce related issues. Tell us more.
Yeah, absolutely. So as you said, kind of hot off the presses of an additional study that we did with all the information that we receive here, we were trying to assess one of those factors, in particular that Tiffany mentioned, of turnover rates. And so we did a study looking at over 500,000 employees. We were very specifically looking at employees for the study. Again, over 500,000 of them over about 191 different groups. And what we found was that the turnover rate for employees that were engaged with Marathon Health was significantly lower than those that don't have this benefit available or are not engaged. The average turnover rate for those unengaged was about 13% annually, whereas the turnover rate for the engaged population is sitting closer to 8%. So again, fairly significant reduction there in trying to express the wider ROI story, if you will, outside of just financial impact. Not to say there isn't a financial impact there as well due to recruiting and having to train up a new resource and potentially overtime pay from affecting turnover. But in addition, just being able to keep your employment forces intact, if you will. Similar, I do want to mention, given the astute question earlier in the call, is that a uniform result? Again, very little in life is a uniform result. So this is also not uniform. What I will tell you is that about 70% of those 191 groups saw improvement in their turnover rates. The other 30% saw either equal, meaning the turnover rate didn't increase or decrease, and then some that it actually increased instead. So about 70% success rate of clients seeing a reduction in turnover rate in line with engaged versus unengaged populations in their groups. So.
Great. Well, thanks very much to you both, Marcus and Tiffany. Thanks to the audience. Hope you've enjoyed the session today. We will circulate a recording of this that you're free to distribute. There's a white paper that details more of the two analyses that Marcus walked us through that we will also circulate. And last and most importantly, the door is open if and when you have questions. If you're an existing client and you want to know more about ROI, please work with your account manager to get us your questions. If you're a prospective client or a broker and you want to talk more, we're happy to connect you with folks on our side to carry on the conversation. Really appreciate it. Look forward to next time. Thanks very much.
Thank you.
Thank you, Nirav. Thank you, everybody.